Dr. Arno, we can get
Yes,
started.
Okay.
Yes.
Hello, everyone. This is Dr. Arinova. I'm one of the gynecologists in Illinois and will be a moderator to Vital Health Foundation's today's monthly talk. Our topic today is contraception care counseling, which is going to be presented by Dr. Sarah Wetston. Welcome, Dr. Wetston, to our today's presentation. So Dr. Wetston is an associate professor and residency program director in the Department of Obstetrics and Gynecology and Reproductive Sciences at UCSF. Her work as a clinician educator is grounded in the principles of reproductive justice and health equity, and it has focused on aligning educational and clinical training to the needs of our population by centering the experiences of the most underserved individuals and communities, especially Black women. She has worked tirelessly around issues of workforce diversity, leading one of the most diverse training programs in the country. And she has developed an innovative curriculum that prioritizes social justice and structural competency. Additionally, she serves as one of the associate directors for the Black Women's Health and Livelihood Initiative, and previously served as the interim vice chair of equity, inclusion, and structural change for her department. Dr. Wetston, welcome to the meeting.
Thank you. Good afternoon from California, good evening, or whatever time it is in whatever corner of the world you find yourself. Thank you for that introduction. I'm happy to discuss one of my favorite topics, which is contraceptive care and counseling. I have no disclosures. My hope is that by the end of this presentation, you are inspired to provide patient-centered contraceptive counseling, that you feel comfortable using the CDC medical eligibility criteria and selected practice recommendations, and that you have 2 to 3 very practical tips about initiating and prescribing different contraceptive methods. If you don't have this app now, I highly encourage you to download it. I'm going to reference it throughout the talk. You can search the term CDC contraception, but it contains both the US medical eligibility criteria and selected practice recommendations for easy access on your phone. In our short time together, we're going to talk about the 4 topics. The first is going to be contraceptive counseling. We'll move on to how to use the US medical eligibility criteria and selected practice recommendations and focus on prescribing the pill. Then we'll talk about elevated BMI and contraception, and hopefully we'll have time to discuss emergency contraception. All right, let's start with case 1. We have Felicia, who uses she, her pronouns. She's a 24-year-old Gravida 8 Para 1 woman who presents to discuss contraception. She has no significant medical or surgical history. She has 2 male partners currently. She smokes 1 to 2 cigarettes on the weekend, otherwise does not have any toxic habits. Up to date with her cervical cancer screening, has had 1 vaginal delivery and 7 abortions. Her family history is unremarkable. So if she's coming to see you for contraception, what would you recommend? A LARC method, which stands for long-acting reversible contraception, like an IUD or implant. Depot medroxyprogesterone acetate, the injection or the shot. Oral contraceptions, permanent sterilizations, condoms, or you don't know. I'll give you just a moment to think about what you would recommend for this person. Well, when I was a resident, I used this diagram frequently to counsel on contraception. I was actually advised to do so. I was supposed to give primacy to the most effective methods, which include the long-acting reversible contraceptive methods, including the IUD and implant, and the permanent forms of contraception, male and female sterilization. Then after sort of focusing on these most effective methods, then I would talk about sort of the moderately effective methods, including the injectable contraception, the contraceptive pill, patch and ring, and diaphragm. And I was really advised to spend little time on the less effective methods. But since residency, I've learned a lot about contraceptive counseling and learned even about my own biases and errors in counseling. And I've really learned that counseling based on efficacy does not really sort of center patients. It assumes this very binary approach to pregnancy. Either you really want it or you really don't. And we've actually learned that, this way of counseling is erroneous. It assumes that all individuals want to use a long-acting reversible contraceptive method or permanent sterilization. It really ignores this variability and preference. But even more so, that pressure to use specific contraceptive methods is counterproductive. It increases dissatisfaction, mistrust, and actually is associated with greater contraceptive discontinuation. Plus, we know that pressure to use certain methods is an example of low quality care and coercion. And there is an abundance of evidence of both individual and systematic coercion in the realm of contraception. And so really, to be honest, I've abandoned that diagram. I've abandoned sort of counseling based on sort of efficacy as the most desired feature of contraception. And so we know that it's much more than that. And so over the next few moments that we have together, I'm hopefully that I can emphasize that. Several years ago, one of my colleagues shared this pictograph with me. And to be honest, it was kind of eye-opening and life-changing in sort of how I thought about contraception. So I'm hoping to share it with you, and hopefully it will also have an impact on you. And so this pictograph demonstrates the number of individuals who will become pregnant in 1 year out of 1,000 based on typical use of the various contraceptive methods. If we start with our long-acting reversible contraception, like IUD and implant, about 2 individuals out of 1,000 will become pregnant in 1 year. If we go to the contraceptive injection or depot-medroxyprogesterone acetate, about 60 out of 1,000 will become pregnant in 1 year. So definitely more than the long-acting reversible contraceptive methods, but still overall great contraceptive protection. If we move to the combined hormonal methods, the pill, patch, and ring, about 90 out of 1,000 will get pregnant in 1 year. So again, far more than the LARC methods, but still pretty good. And then if we move to condoms, about 180 out of 1,000 will get pregnant in a year. But if we compare that to no form of contraception, we estimate approximately 850 individuals out of 1,000 will get pregnant in 1 year. So if we compare condoms, which we think of as one of the least effective methods, we still see it as far more effective than nothing in preventing pregnancy. And so this really changed the paradigm for me about sort of how to think about contraception. Granted, there are varying levels of efficacy amongst the different contraceptive methods, but any form of contraception will prevent more pregnancies than no form of contraception. So it's about really helping people choose the form of contraception that they will use, as that will always prevent more pregnancies than nothing. And so given this sort of historical context and documented disparities in access to contraception and coercion around contraception, it's really essential that we focus on preferences in contraceptive care, especially for those individuals who have been historically excluded and marginalized within our medical systems. And so if we move to this paradigm of contraception being more than just about efficacy, then let's talk about what I think are some very basic sort of principles and approaches to contraceptive care. One, it's a preference-sensitive decision. We have to respect and honor the diverse perspectives, priorities, concerns, and experiences, both at the individual level and at the community level. We also know that contraceptive counseling matters, and that we as providers can play a role in helping patients choose the contraceptive method that is best for them. And that's often a decision that is highly contextualized based on where people are in their life experiences, what their family members and friends have experienced, what their goals, what their priorities are. But we know that what we do in terms of contraceptive counseling is associated with method continuation. And then when providers express a preference for a contraceptive method, it's associated with lower satisfaction. And even more, it's associated with a with a lower likelihood of even starting a contraceptive method. I'm sure many in the audience are familiar with the sort of shared decision-making model around medical decisions. This is a model where there are 2 or more medically appropriate options, and the choice for an individual depends on their assessment of the relative importance of different characteristics or potential outcomes. And the healthcare provider's role is to share their expertise and medical knowledge, while the patient or individual shares their preference on their values, goals. And then they work together to identify a decision that is most consistent with the patient's preferences. And in contraceptive counseling, this is an optimal model. And we have evidence that when patients engage in shared decision-making with their providers around contraception, they're more satisfied with the decision-making process. And they're even more satisfied with their method of contraception. Great. So how do I counsel people about contraception? Well, I usually start with a key question. I usually ask them what's the most important thing to them about a method. Are they looking for their ability to start and stop it themselves? Are they having concerns about safety, about return to fertility, how they administer it, efficacy in preventing pregnancy, concern for or desire for side effects? And usually understanding the most important feature will then help me identify what contraceptive options would be best to counsel a patient about. Additionally, I have some other key principles. I always seek permission to share information about contraception. Unfortunately, there's a lot of misinformation available about contraception. And we make a lot of assumptions about what people do or do not know about contraception. And I find that it is my responsibility as a medically trained provider to provide evidence-based medicine and evidence-based counseling around contraception. And so I always ask my patients if they're open to me sharing my expertise. Additionally, I use simple language. I often use pictographs. When talking about side effects, I often use things like 1 person out of 4 will experience this side effect to help people contextualize sort of their potential risk of experiencing something. I think it's very important for us to be forthcoming about side effects, especially about changes in bleeding, and I'll talk more about this momentarily. I also always acknowledge the possibility of dissatisfaction. It's hard to know whether someone will like something until they try it, and then make a contingency plan if they are in fact dissatisfied. And then I will be honest, I always give space to ask questions. People have lots of questions about contraception because there's so many myths and misconceptions about reproductive and sexual health. I've heard many, many crazy and off-the-wall questions, and part of this suggests that people were not given the privilege of evidence-based information, and I really want to give space to make sure that I answer those questions and respond in a dignified and humanistic way. I do just want to highlight this sort of transparency around side effects. In an older study, we know that the leading reason that people discontinue contraceptive methods is they experience side effects that they did not desire. The second most common reason was changes in their menstrual cycles. And so I think it is our obligation not only to talk about contraceptive methods in the positive, how it could improve menstrual periods, how it will help prevent pregnancy, but also to acknowledge that contraceptive methods frequently involve the initiation of hormonal therapy, and that those are associated with potential side effects. I feel especially sort of passionate about talking about menstrual changes and contraception, and this has to do with a lot of the history of contraceptive coercion and how in many communities contraception was used to control populations, control fertility, and oftentimes that is sort of interpreted as sort of changes in menstrual cycles. These are just 2 of many studies I could cite about sort of individuals' sort of perspectives and sort of hopes around sort of contraception and changes to their menses. And a focus group of adolescents of color, they really express concern that changes in their menstrual cycle from contraception was evidence of reproductive harm. And in a multivariate analysis of Black, Latinx, and Asian Pacific Islander women, they really desired a method that did not change their menstrual period as an important contraceptive feature. And so I think this is really important when we talk about contraception, that we talk about its impact on people's menses and their bleeding. We also have really good evidence that the care that we provide individuals while they are seeking contraception makes a difference. So patients who reported that they had high quality interpersonal care were more likely to be using a highly or moderately effective method at 6 months, and were more likely to maintain their chosen contraceptive method in comparison to people who did not experience high quality interpersonal care. Well, what are features of high quality interpersonal care, you may ask? Well, two salient things include investing in the beginning and eliciting the patient's perspective. Investing in the beginning entails showing familiarity, greeting patients warmly, using open-ended questions, eliciting the full range of concern. Eliciting the patient's perspective specifically means exploring their experiences with birth control, their preferences for birth control, and showing how that we care about the impact of birth control on their life. So now that we sort of talked about sort of some of the key principles and approaches to contraceptive care counseling, then we return to this sort of model of shared decision-making, and we return to Felicia's case. So we are going to share our expertise as providers about, is a certain method safe? How do we start it? How do we maintain it? And we're going to center our patients' preferences. So earlier, when I asked you what was the sort of contraceptive method that we should recommend for Felicia, the answer is we don't have enough information about her to make a recommendation because we did not elicit her preferences. Once we elicit her preferences, then we can provide more evidence-based counseling and care for this individual. So in this case, Felicia reports that she's uncomfortable with any form of hormonal contraception. And so that leads us with the options around non-hormonal contraception, which includes nothing, fertility awareness, coitus interruptus, condoms, non-hormonal vaginal gel, the diaphragm, and the copper IUD. And then helping her navigate this is where the fun, the excitement of contraceptive counseling is. It's understanding her perspectives and her goals. Now, throughout this presentation, I'm going to highlight some contraceptive methods that may be less familiar to everyone. That's because they're newer or they're less routinely available, but just to make sure that we expand our knowledge of contraception. Here is one. This is the single-size diaphragm. This is relatively new. It's on the market and its brand name is Kaya. It's made from silicone. Unlike previous diaphragms, it doesn't require a pelvic exam to fit the diaphragm. It fits approximately 95% of all individuals. The pregnancy rate is about 14% in a year, and spermicidal gel increases the efficacy in preventing pregnancy. This is something you can order at the pharmacy and patients can pick up and use. All right. So now we've covered some basics of contraceptive counseling and really centering patients' preferences. And now we're going to move on to the US medical eligibility criteria and selective practice recommendations. So here we have case 2. This is Lila. She uses she, her pronouns. She's a 29-year-old G0. She presents because she wants contraception to prevent pregnancy. Her past medical history is notable for chronic hepatitis B with an undetectable viral load. Her surgical history is non-contributory. She has 2 male partners, smokes a few cigarettes on the weekends, has about 6 drinks a week. She has a history of PID, but is up to date with her cervical cancer screening. Her family history is unremarkable. In choosing sort of the best contraceptive method for her, it will engage in shared decision-making. And in this case, she opts for combined oral contraceptive pills. So this is where she needs our expertise about how to start them. Is it safe for her to use them? What physical assessments do we need to do? What screening tests do we need to order? When do we start? And what do we actually prescribe to this individual? And this is where the US medical eligibility criteria and selected practice recommendations come into play. We'll start with the US medical eligibility criteria. If you don't have this app, again, my reminder, download it. It's awesome. You can use it frequently. So always, I ask people if they use this in their practice. And if you don't, then, and you take care of people at risk for pregnancy and who desire to prevent pregnancy, I highly encourage you to download it and to start using it. So for those of you who haven't seen it, this is the summary chart for the US medical eligibility criteria. You see lots of words, columns, colors. Let's talk about what those mean. Well, the US medical eligibility criteria has 4 categories, and those define sort of any restrictions in use. So category 1 means that there's no restriction in use and you can use that method freely. Category 2 means that the advantages generally outweigh the theoretical or proven risks. So you may need more than usual follow-up, but still okay to use. And you can remember this, that both categories 1 and 2 are green. So green light means go, so you can use them and feel comfortable that you are prescribing a method that is safe for someone to use. Category 3 and 4 are sort of shades of red and pink. And these are categories that we should in general avoid. Category 3 means that the theoretical or proven risk outweigh the advantages. We should not use this method unless there are no other methods that are appropriate. And 4 is that there is an unacceptable health risk if the method is used, and we should absolutely not use it. So if we go to an example, you see this is one medical condition. This is VTE, so DVTs and PEs. And you can see subconditions, and you can see different sort of contraceptive methods and their different categories. So in this case, someone who's had a history of a VTE but is not on anticoagulation can have a copper IUD safely. It's rated 1. Whereas someone who's had a history of a VTE and has a higher risk for recurrent VTE should avoid combined hormonal contraception. And so that's how we use it. And in the past, they used to distinguish between initiation and continuation. They have done away with that. So if we go back to Lila's case, Lila's sort of only significant medical history was that she had chronic hepatitis B. So if you use the US medical eligibility criteria, hopefully you have it on your app, but you can also use the summary chart online. Sort of what is the category for combined oral contraception or combined hormonal contraception for individuals with chronic viral hepatitis? In the interest of time, I'll just give you the answer, but it's 1, meaning that it's safe and reasonable to use. It is green. So then what do we need to do before we actually start it? So we've determined that combined oral contraceptive pills are safe for Lila. Then what do we need to do for her? Well, this is where we turn to the selected practice recommendations. And they rate sort of examinations and lab tests as A, essential and mandatory in all circumstances for safe and effective use, or C, does not contribute, does not contribute substantially to the safe and effective use of the contraceptive method. If you look at this sort of table, most of these examinations or laboratory tests are C's, meaning we don't have to order labs for starting any contraceptive method. The 2 exceptions you can see are that a bimanual exam and cervical inspection are needed for IUD insertion, and that a blood pressure measurement is needed for initiation of combined hormonal contraception. Otherwise, we don't need anything. So that means that what we are trying to do is lower the bar for initiation of contraception so that more people have access to it. So in general, we don't need tests or examinations before we start birth control. And I told you about the 2 exceptions. And it's just also really important to emphasize that weight measurement is also not needed. All methods can be used regardless of someone's BMI or body weight, and we'll talk a little bit about this later. Sometimes it's helpful to keep track of people's weight, as oftentimes sort of weight concerns come into play when people are thinking about the optimal contraceptive method for them. And so now that we know, since she wants combined hormonal contraception, we need a blood pressure measurement, but then when can we start? And again, that's where we turn to the selected practice recommendations. So for this individual, we can start anytime if we are reasonably certain that they are not pregnant. If they're beyond 5 days from the start of their period, then they need to use a backup method or abstain for 7 days to allow the method time to work and prevent pregnancy. Well, how do we know if we're reasonably certain someone is not pregnant? Well, there are defined guidelines. It includes being within a week of your period, not having sexual intercourse that puts you at risk for pregnancy since the start of your last menses, that you're correctly and consistently using a reliable method of contraception, you're within a week of a miscarriage or an induced abortion, you're within 4 weeks postpartum, and you're fully or nearly breastfeeding, amenorrheic, and within 6 months postpartum. If you fall into these categories, you don't even need a urine pregnancy test before starting contraception because we can be reasonably certain someone's not pregnant. But we know that's like the most ideal categories, and that doesn't always happen in life. So what if you're uncertain if someone is pregnant or not? Well, the recommendation is that we should start contraceptive methods at any time, maybe with the exception of the IUD, and then tell someone to take a pregnancy test in 2 to 4 weeks. The rationale is if someone does not desire pregnancy, it doesn't make sense to make them wait, confirm that they're not pregnant, although they're still at risk for pregnancy while they're waiting to confirm they're not pregnant. Just have them start it. Have them start sort of getting the benefit of contraceptive protection. And if they're pregnant, then you can deal with that later. But there's no evidence that there is adverse outcomes from in utero exposure to combined hormonal contraception, to depot-medroxyprogesterone acetate, which is the contraception injection. And so if someone was pregnant and they took a contraceptive method, it would not cause any sort of congenital anomalies, developmental abnormalities, or increased risk of neonatal infant death. So if someone is uncertain that they're pregnant, but they don't want to be pregnant, have them start their contraceptive method immediately and just take a pregnancy test in 2 to 4 weeks. Okay, so for Lila, she can start pills. She can start them right away. She just needs a blood pressure measurement. So then what do we prescribe? Well, this is my tips. So one, we should offer extended cycle, and I'll define what that means. We should prescribe a monophasic oral contraceptive pill. This means the same dose of hormone in each tablet, and we should prescribe a 12-month supply. So extended cycle means that you have fewer hormone-free days. So this can happen sort of in the span of a month. So you can shorten the hormone-free week. There are options where you give 24 days of hormones and then have 4 days of no hormones, as opposed to the classic 21 days of hormones and 7 days without hormones. You can have fewer hormone-free weeks, so you can have 12 weeks of hormones with 1 week of no hormone. Or you can have continuous, where you have hormones every day. There are lots of benefits for this in terms of preventing pregnancy, but it also is effective in sort of the non-contraceptive benefits of contraception, including management of dysmenorrhea, painful periods, ovarian cysts, endometriosis, heavy menstrual bleeding, and so forth. We also have evidence that the shortened hormone-free week is associated with decreased ovarian activity at the end of the placebo pills. You have shorter withdrawal bleeds and lower failure rates, meaning that the 24-day hormonal pill, there is a lower pregnancy rate compared to with the sort of traditional 21-day pill. So it has advantages in many different ways for both contraception and non-contraception to have fewer hormone-free days. Now, if people want to use extended cycle, but they don't like the pill, then they're great options for the ring and the patch. The contraceptive vaginal ring has circulating hormones for 35 days, which means, and there's evidence that it inhibits ovulation for at least 5 weeks. So this means someone can use it continuously. And I often recommend that they just change it on the same day of the month, and they can skip their periods and have great contraceptive protection. Historically, the contraceptive patch was not recommended for continuous use, although a study I used to say a few years ago, but is now over 5 years old, showed that the sort of patch can be used safely in a continuous way for up to 12 weeks. After 12 weeks, people need to take a break from the patch for a week and then restart it. But that is far fewer withdrawal bleeds if they use it for 12 weeks continuously, as opposed to the traditional way, which is 3 weeks on and 1 week off. And then just as another update of something that is sort of relatively new and less known, this is the 1-year reusable ring. It has progesterone acetate and a phenylestradiol. The commercial name is Anovera. It was produced by the Population Council. It is a vaginal ring, just like the Nuva ring, although it has a different sort of hormonal combination. It does not require refrigeration, so can be used freely and easily throughout the world. It is approved for 1 year of 13 cycles, and they do, in the sort of way it was approved, it was studied such that people used the ring for 3 weeks, and then they took it out for 1 week and had a withdrawal bleed. It's patient controlled and reversible and has a similar side effect profile to the Nuva ring or the other contraceptive vaginal ring. And the side effect profile is similar, but very few people discontinue for that purpose. So this is a nice option for people who don't have ready access to a refrigerator, who don't want to have to go to the pharmacy each month and pick up a new ring. All right, so if we go back to Lila, who wanted combined oral contraceptive methods, these are my pearls. Number 1, choose a monophasic pill. Prescribe 30 to 35 micrograms of a phenylestradiol and levonorgestrel. My rationale is that the lowest doses of estrogen, the 10 and the 20 micrograms, are associated with greater bleeding disturbances, which is associated with greater discontinuation. And again, our goal is to help people choose a method that they will use, because that is the best way to prevent pregnancy. There's no clear benefit to sort of triphasic, so monophasic is a reasonable option. The progesterone choice doesn't matter so much. There's no clear benefit to one progestin over another. Drospirenone has been reported to have a higher absolute risk of VTE in comparison to other progestins, so that is not my go-to progestin. There's some suggestion that levonorgestrel may cause lower VTEs and may cause fewer VTEs, so that is my go-to progestin. And then I offer a shortened or absent placebo week. All right. Sorry. And then, as I said, please prescribe a 12-month supply. It shows that people who get a sort of greater supply of birth control pills are more likely to continue it, and that more pill packs are associated with fewer pregnancy tests, fewer pregnancies, lower costs, and actually greater cervical cancer and STI screening. All right, so again, our counseling should be based on shared decision-making. We use the US medical eligibility criteria to check for safety. In general, examinations and tests are not needed. We can start immediately, and we should prescribe a 1-year supply. Now, let's say we still have Lila, but the case is a little bit different. In this case, she has hypertension, and her blood pressures are 150s over 90s. Again, if we go back to our shared decision-making model, we have to make sure that this method is safe for her. So what is the US medical eligibility criteria for someone with hypertension and who desires combined hormonal contraception? Hopefully you're using your app, which hopefully you already had downloaded, but if not, you've downloaded it today. And in this case, it would be category 3. If we remember, category 3 is one we should avoid if we have other options. Now, if Lila feels very strongly that she wants oral contraceptive pills, then maybe instead of combined oral contraceptive pills, which contain both estrogen and progestin, we use just progestin-only methods. And for so long, we really only had one progestin-only pill, and that was the norethindrone dose. You had to take it continuously. It's very unforgiving. You have to take it at the same time every day. You only have a 3-hour window if you don't take it at the same time. It does not reliably suppress ovulation. I find that this is a very hard pill for people to take regularly. Well, recently, maybe recently is an exaggeration, but in the last few years, another progestin-only pill came on the market, and that was the drospirenone only. It has 24 active pills and 4 placebo pills. It allows greater flexibility. You can take a dose up to 24 hours late as opposed to within 3 hours. It reliably suppresses ovulation, and it has efficacy similar to combined hormonal contraception. So this could be a great option for Lila, who desires to take pills, but because of her hypertension, cannot take pills with estrogen. All right. If we move to case 3, we have Jill. This is a 35-year-old individual who's sexually active with 1 male partner. She uses condoms consistently. Her friends use depomedroxyprogesterone acetate or the injection. She wants to know more about it. She has very heavy periods. She's also worried about weight gain with contraception. Her BMI is notable for a BMI of 44. Otherwise, she has no significant medical surgery or gynecologic history. So I will say that questions about weight come up all the time. I just also want to highlight that during the pandemic, there was a new way that people could get depomedroxyprogesterone acetate. In the past, we primarily had the intramuscular form available, which required people to go to a healthcare facility and have it administered. And then during the pandemic, sort of public insurance more readily covered the subcutaneous forms, which allows patients to give themselves depomedroxyprogesterone acetate. The dose is slightly different and the duration is slightly different, but it's still an awesome option for people if they desire it. All right, let's talk about weight and contraception. This is such a predominant conversation and discussion topics, and many questions come up. Does a method cause excess weight gain? Is the failure rate higher in individuals with an elevated BMI who are using a particular contraceptive method? Are there medical risks attributable to the method in individuals with higher weights in comparison to those with average weight? We can use the US medical eligibility criteria to help us answer this question. Well, in large population studies, only one contraceptive method is associated with weight gain. And that is depomedroxyprogesterone acetate. And actually, it was only seen in about 25% of individuals. And those who gain weight were either adolescents with elevated BMIs, or they gained greater than 5% of their body weight within the first 6 months of use. Other than that, there is no evidence in population studies that the pill, the patch, the ring, the implant, the IUD, and even tubals are associated with weight gain. And I think it's just really important to emphasize because there's a lot of concern about how contraception affects people's weight. We also, is there an increased risk of failure rate in individuals with an elevated BMI? Well, the answer in general is no. The one exception may be the patch. And this was not sort of borne out by randomized control trials. It was only seen in post-marketing data. There was a very small number of pregnancies seen among people who used the patch. And in those individuals, the vast majority had a weight higher than 90 kilograms. And so we still don't have randomized trials that suggest that there's an increased risk of failure of the contraceptive patch in people with higher BMIs, but it is part of our counseling that it may be less effective in people who have a weight higher than 90 kilograms. We know from studies that obesity is a risk factor for VTE, and that the combination of combined hormonal contraception and specifically combined oral contraceptive pills and obesity increases the risk for VTE. And we extrapolate that that is true for the patch and the ring. And we have no evidence that depomedroxyprogesterone acetate is associated with increased risk in people of higher BMIs, and same with the implant. And then if you look at the medical eligibility criteria for these different contraceptive methods, and for individuals with a BMI of greater than or equal to 30, it is 1 or 2, meaning that it's safe and reasonable to use. So this, I think, provides a lot of reassurance about contraception and weight. But after we talk to Jill, she's nervous about the risk of sort of weight gain with depomedroxyprogesterone acetate, and actually opts for a levonorgestrel IUD. And so for the levonorgestrel IUD, we can start at any time we are reasonably certain she's not pregnant. If she's within 7 days of her period, she doesn't need any backup, but if she's more than a week, then she will need backup. And then remember, to start an IUD, you have to do a bimanual exam and look at the cervix. And then I also just think it's really exciting that we can use IUDs for sort of longer periods of time. And I will say, it used to be when I first started sort of talking about extended use of IUDs, we were saying that we had advice that differed from the FDA, and now in general, our advice aligns. So the copper IUD, which is a non-hormonal IUD, is approved by the FDA for 10 years. For people who are younger than 35, you can use it for 12 years. And for people who are over the age of 35, they can use the IUD until they transition to menopause. For the 52 milligram levonorgestrel IUD, which is known as Mirena or Liletta, it is approved for now 8 years, which was exciting. When it first came on the market, it was 5, then it went to 6, and in August, it was approved to 8, which is awesome. The lower dose levonorgestrel IUDs are approved for 3 and 5 years, and there is no evidence for extended use. But this is awesome because it allows people to have contraceptive protection for a much longer time than we initially anticipated. I also think it's just really important to be mindful of sort of rates of amenorrhea or people not getting their period on the IUDs. Although my dream is not to have a period again in my life, there are many people who find not having a period disconcerting. It sort of contradicts what their notion of a healthy body is. Sometimes it conflicts with cultural practices and so forth. So that's why I think as I said, when I counsel about contraception, I do talk about the impact of the contraceptive method on their menstrual cycles. It's just important to remember the first 90 days, very few people become amenorrheic, but by a year, about 20% of those with the highest dose levonorgestrel IUD become amenorrheic, and about 6% with the lowest dose hormonal IUD. So just really important to tell people that, as that can be very disconcerting for many. For a lot, it's sort of the reason they choose it, but I do think we just need to be transparent in our contraceptive counseling. And then just as a reminder, there's still lots of barriers to IUD use. There are a lot of misconceptions about the safety and appropriateness of IUDs, especially in young people, people who haven't
Dr. Whitstone, I think we lost your audio.
Can you hear me?
Yes, it's fine now. It's better now.
Great. Sorry, my headset must have eventually died. So then I'm not sure where I was, but I'll just keep going in the interest of time. And then there are a lot of concerns about pain with IUD insertion, and it's just really important that we offer local anesthesia at the time of IUD insertion so that we can make the procedure less painful for people. And so just to wrap up case 3, we have limited evidence around contraceptive failure and elevated BMI or weight. We should really strive to minimize the barriers for IUD insertion, and we should encourage extended use of IUDs. And then I'm going to spend 2 minutes on emergency contraception, and the reason being, given the increased restrictions on abortion across the country, it is really important that we help people who do not desire pregnancy to not be pregnant, and emergency contraception is one option. So for many years, we had 3 options. The copper IUD, which was almost 100% effective and can be used up to 5 days after unprotected intercourse. Then we had ulipristal acetate, which is a selective progesterone receptor blocker, which can work up to 5 days. It's less effective than the copper IUD, but still more effective than levonorgestrel oral emergency contraception, which is known as Plan B. That is best used in the first 3 days, but can be used for up to 5 days. Last year, there was a randomized non-inferiority trial published in the New England Journal of Medicine that showed that the levonorgestrel 52 milligram IUD was non-inferior to the copper IUD when used as emergency contraception. So excitedly, now we have 4 options. We have 2 IUDs and we have 2 oral forms of emergency contraception. Remember, one of the benefits of the IUD is it not only acts as emergency contraception, but it also provides enduring contraceptive protection. And I'm not sure if you could see the small print on this diagram, but I circled, there are some sort of concerns about the efficacy of the around the form of oral emergency contraception and weight. Let's look at this a little bit more closely. There is evidence that for both levonorgestrel and ulipristal acetate that it may be less effective for people with higher body weights. The levonorgestrel data is probably the most concerning. It found that levonorgestrel emergency contraception was no more effective than placebo for patients who had weights greater than 155 pounds, which is quite low, and that ulipristal acetate was less effective for weights greater than 198 pounds. That being said, it's very clear that we should not restrict access to oral emergency contraception based on weight. Nonetheless, here are some pearls about emergency contraception. We should give it to anyone who wants it. We should offer IUDs to patients. They're the most effective form of emergency contraception, and then offer long-term contraception. If someone desires oral emergency contraception, we should offer ulipristal acetate. It's the most effective. It's more effective at higher body weights, and it's more effective on days 3 through 5 after unprotected intercourse. The caveat is if you give ulipristal acetate, you cannot start hormonal contraception because it may lower the effectiveness of ulipristal acetate. So you need to wait 5 days after ulipristal acetate before starting hormonal contraception. If someone does want to start hormonal contraception immediately, you should give them levonorgestrel, and you can adjust the dose based on their body weight. We should also consider prescribing ulipristal acetate for advanced provision of emergency contraception. There's good evidence that those who receive emergency contraception in advance are more likely to use it and more likely to do so promptly after unprotected intercourse. And just as a reminder, for people, when you prescribe emergency contraception, they should take it as soon as possible after unprotected intercourse. They have to abstain or use contraceptive protection in the next 7 days because emergency contraception just delays ovulation, but it doesn't prevent it. And then if they don't have a withdrawal bleed 3 weeks after taking emergency contraception, they should take a pregnancy test. So just as a reminder, IUD is the most effective form of emergency contraception. We talked about sort of why ulipristal acetate, it's sort of better at higher body weights and for all individuals at days 3 through 5. And with that, I'll stop and happy to answer any questions you may have.
Dr. Weston, thank you so much. It was such an amazing, informative, and excellent presentation. I'm not sure people will still have questions after such a nice presentation. It was so detailed and everything was like an OBGYN. I can say like it was like really a beautiful presentation, I think, for everyone. And the main points that you touched, they were all really very important points. Like we all know, half of the pregnancies in United States, it's like an unintended pregnancies. So you probably have in your experience too, when they come in for prenatal care, most of them, they tell, no, I didn't plan this pregnancy, it just happened. So I think this was a really very important topic, the contraception care and counseling. And I think it was really beneficial for everyone who was listening and hopefully who will be listening in the future through the YouTube. So thank you.
My pleasure.
So let me see if there are any questions. Let's see.
I have a question. Does it have to be by chat?
No, I don't think that's required. So go ahead, please.
Thank you so much for the presentation, Dr. Redfield. I am a neurology resident, so I wanted to ask about the side effects or cautions of using the oral contraceptives. I know that it increases the chance of, even though slight, of increases of blood clot formation, etc. Is there any contraindication to use it in stroke patients, or do you recommend any dose adjustments?
I heard part of your question, but the other part was difficult for me to hear, but please correct me if I'm wrong. You asked about sort of the risk of contraception and stroke and VTE risk, is that correct? Okay, I'm going to assume it's correct, and I'll answer that question, and then I can answer any follow-up. Well, I mean, we always—
Sorry, I was having a problem with my microphone. Yes, that's correct.
Okay, great. So, I mean, we think very carefully about that. That's why we have to take a history, and that's why the U.S. medical eligibility criteria is so helpful. It is clear that sort of people who have a history of VTE, we should steer clear of sort of estrogen-containing contraception, but then that means that we can safely use most progestin methods without significant concern. Similarly for stroke, it depends on sort of the etiology of stroke, but again, we also sort of avoid estrogen-containing methods in general for stroke. Sometimes we also think about sort of we think about the impact of depo on hypoestrogenism, but I will say that most progestin methods can even be used safely in patients who've had a history of stroke. But again, the US medical eligibility criteria will have sort of stroke as one of the conditions. And so you can look at sort of whether a specific method is safe with someone's history.
And this recommendation also includes the emergency contraception as well? Or
Yeah.
is it for regular use? Well,
emergency contraception doesn't have any estrogen. So it's either the copper IUD, which has no hormone, or progestin-based, which can be used in all those settings. I think the other thing that's always important to remember, whenever we talk about contraception, we obviously don't want to increase anybody's risk of sort of an adverse outcome with contraception, but almost always contraception is safer than pregnancy. And so always we sort of think about contraception in light of someone's medical conditions, but if you look at sort of the risk of contraception versus the risk of pregnancy, the risk of pregnancy almost always exceeds the risk of contraception. So it's always just important to think about when we are sort of helping people make decisions about what's best for them.
thank you so much. I really appreciate it.
My pleasure.
Okay, there is a question which came up through the chat. Do you have a preferred method for adolescents?
Yeah, that's a great question. So I don't have a particular method. So I think it's about sort of helping people choose what's best for them. So sometimes the sort of questions are, you know, what is something that you can use reliably? Some people can take a pill every day. I find that sort of a little more challenging in adolescents, but some of them can. Also, sort of, is this something that they have shared with their family members, or is it something that they haven't shared with their family members? You know, I practice in the state of California, so adolescents can seek contraceptive care without seeking their parental permission. So really, it's about helping an adolescent choose what contraceptive method is best for them. In the past, people were very hesitant to provide IUDs to adolescents because they had not had pelvic exams, they had not had pregnancies, but an IUD is an awesome and safe choice for an adolescent. So I will say that my sort of counseling really goes back to what does somebody want and sort of what will work best in their sort of lifestyle.
Okay, thank you. Let me see. Okay. I don't see any questions so far.
Well, I hope we achieved our objectives. I hope people feel inspired around contraceptive counseling. And I really do think that although I'm an OBGYN and exceptionally passionate about it, I think if sort of more physicians and providers across specialties talked about contraception, hopefully we could sort of make sure that it was more accessible to people and that they make decisions that they feel are best for themselves.
Yes, I agree. So actually, a question came up while I was talking when the neurology, I didn't catch doctor's name from the neurology, like patients with seizure disorders, they take like anti-seizure medications, which can interact with birth control pills. What is your approach to those patients?
Yeah, well, this is a perfect example of the U.S. medical eligibility criteria. So some, anti-epileptic or anti-seizure medications interfere with metabolism of birth control pills, and some do not. And so it's sort of a discussion with their neurologists about sort of what medications they're on, and whether the anti-epileptic or the contraceptive will be affected by either. And if that's the case, it's often finding a different contraceptive method, or working with a neurologist to adjust their anti-seizure medication. But usually it's that the seizures are controlled by their medication. And so often it's just thinking about a different contraceptive method that is still acceptable to a patient.
Thank you. Okay, I believe everything was so informative. I think we have no questions at this time. Everyone is thanking you through the chat there. Everyone is applauding and saying it was such an informative and excellent presentation. So thank you so much for your time, Dr. Weston.
You're welcome. Thank you all for being here. Thanks for the invitation. Have a
Thank you.
beautiful day. Bye.